Okay, I want to welcome everyone to Cardiology Noon Conference today. We have a very special presentation today by Dr. Gabriel Hernandez. Dr. Hernandez is one of our new young faculty members. He's come to us from Miami, where he finished his cardiology fellowship. He went to Vanderbilt for advanced training in advanced heart failure and transplant, and then went back to Miami and finished an interventional cardiology fellowship. So we felt that he would be a great one to present a topic on the cardiovascular implications of COVID-19, since there's a combination of ST elevation myocardial infarction as well as myocarditis. So thank you, Gabe, for agreeing to do this. I'll turn it over to you.
Thank you, Dr. McMullen, for your kind introduction. So today we're going to talk about this terrible pandemic we're living, that is the COVID-19. We're going to talk about, summarize and update current information about SARS-CoV. Also, ID background, epidemiological background, noting that I'm not an epidemiologist or an infectious disease doctor, so just bear with me. I'm a cardiologist talking about things that are outside my field of expertise. I'm going to talk about a pathophysiology, which I think is key for the cardiologist to understand what is the cardiovascular impact of the disease, treatment plans, and advanced therapies that may be needed. It is important that you protect yourself when you're out there taking care of COVID-19 patients. Use the PPE, the protectional equipment, as your hospital's guidelines recommend you to do so. In our cath lab, we're doing I-95. It's not mandatory to use I-95 if you're not exposed to aerosols. However, we know that patients that come to the cath lab are in imminent risk of dying, and we may need to intubate, do CPR, so we need to be prepared for the worst and hope for the best. Napoleon once said, "Dress me slowly, I'm in a hurry," and this makes so much sense during this crisis. We're in war, and you need to take time to dress up yourself, because if you make a mistake, either you don't notice and you're going to get yourself exposed, or you notice, you have to stop, break the scraps, do it all over again, waste time and PPE. So in 2019, December, a cluster of respiratory illnesses was linked to a seafood market in Wuhan, China. In January 3rd, a coronavirus was identified. It was the 2019 coronavirus that was isolated with a BAL in a patient infected in Wuhan. Back in the day, it was called novel coronavirus associated or infected pneumonia. In January 9, a full genome sequence of this gene was identified, and it was known to be a beta coronavirus, which is similar to the SARS-CoV-1 and the MERS viruses. It was named SARS-CoV-2, and the disease associated with it was called COVID-19. SARS-CoV-2 has very close similarity to the VAT coronavirus, and is probably the primary source. And the first report from China, from Wuhan, showed that for the first 31st cases, 60% of them were linked to this market. It was Huanan seafood and wholesale market. And in January 12th, we already had this spreading. It was an outbreak and announced by the World Health Organization. By January 14th, the disease got to Thailand. A patient that was sick traveled from Wuhan to China. Then 2 days later, the disease was in Japan. Another patient got from Wuhan into Japan. This person, interestingly enough, was not in contact with the seafood market. However, he said he was in contact with somebody who was sick with pneumonia. January 21st, the disease spread out to Korea. This patient, interestingly enough, was never in the market, was not exposed to anybody sick. So we learned that the disease was person-to-person contact, and you do not need to be symptomatic to spread the disease. That same day, the disease was noticed in Seattle, and the CDC came out with the communication that this is got to the United States. Right now, as of early of this morning, this is how the pandemic looked like. Almost 1 million cases, and 200,000 of them recovered, but the death toll was as high as 45,000, unfortunately. This is how the United States map looks. All states are infected. Back to the first report from Wuhan, 41 patients. This was an amazing rate, and learned about a lot of epidemiological details that we just take for granted, but they went back and looked at all the first patients infected. And the first 4, only 1 was actually exposed to this market. The other 3 were not. So it's hard to know which was the index case that spread the disease, but we know that 66% of patients were in the market and then got infected. And 15% of them died. And this is how the disease spread. So how the disease progressed. From no symptoms to hospital admission in 7 days, ERDS by day 9, and ICU admission. And this is fascinating how they realized and they published that patients that were sick were actually hypertensive. And I'm going to go back to that, and it's very important finding. So the coronavirus is an RNA virus, which is broadly distributed to humans and mammals. Most of the coronavirus infections are mild, and this is one of the causes of the common cold. However, there are some strains like SARS and MERS that are very pathologic with a mortality rate of 10% for SARS and 37% for MERS. Coronavirus that are identified, probably the tip of the iceberg, and there's many viruses to know, and they just need the right time to do these snowball effects like the SARS-CoV-2 had and caused this outbreak. If you understand the RNO, which is a mechanism of, or the way of tracking how many patients can be affected by one single patient, the coronavirus had an RNO of around 2.5 compared to SARS that has RNO of around 4 and higher fatality rate. Nevertheless, coronavirus had made it a pandemic out of it. And if you look in comparison to the timeline of both of them, coronavirus, the first coronavirus, SARS, took 5 months for the disease to be controlled with 5,000 infected patients. However, we're 4 months out for the SARS-CoV-2, and we have almost 1 million cases. So why are we seeing this effect with SARS-CoV-2? A lot of things we're going to be learning in the future, but looking back at a half-life of the virus in aerosols takes around half-life of 2 hours, less than 2 hours, pretty similar for SARS-CoV-1 and SARS-CoV-2. 7 hours in stainless steel and around 8 hours in plastic, but pretty similar. This is a person-to-person spread, so if you are in close proximity to somebody that has the disease, you're likely that you're going to get it. And interesting for SARS-CoV-2 compared to SARS-CoV-1 is that asymptomatic patients or mildly symptomatic patients can transmit the disease. There's one theory that SARS-CoV-1 is so pathologic and so many patients got ill that they were isolated rapidly compared to SARS-CoV-2, that there are patients or people walking around with the disease. So 3 feet is for you to get droplets, but if the patient's coughing, you can be far apart and still get a droplet. Aerosol is another method of transmission. More important than aerosol is the fomites, that is the aerosol landing into a place where you're gonna, like a handle, rail, or your daily equipment. So 4 major proteins that we need to know, and one of them very important for cardiologists, which is the spike or the S protein, which is this one here in pink. Many coronaviruses are known, but those who share the spike proteins are the ones that affect the human. So the infectivity of the virus depends on this sequence of proteins. And we've all heard about angiotensin converting enzyme, and it's not the ACE that we learn in school, it's the ACE2 that causes the virus to enter the cell. And if you go back to your days in med school, I actually had to go back to my Guyton Hall book to read a little bit more about it, even though I took a lot of things for granted. I never heard of ACE2 before this. And if you see how liver produces angiotensin, angiotensin is cleaved to angiotensin 1 by renin angiotensin 1 to angiotensin 2 by ACE, or angiotensin converting enzyme, and then angiotensin 2 will do its effect by linking to the angiotensin 2 receptor, most of them the ATR1 receptor. Right? We have not talked about ACE yet, ACE2 yet. However, it creates a lot of confusion because people talk about ACE2 as ACE2 receptor. ACE2 is not a receptor for the human biochemical process. It's an enzyme. But because people talk about ACE2 receptor, people misunderstand the ACE converting enzyme 2 with angiotensin 2 receptor, which are two different things. And even there was a paper published about this, and they misinterpret ACE2 with angiotensin 2 receptor. So what is ACE2? So this is a full pathway. We usually cut it in half and talk about what is relevant for cardiologists, but we don't talk about the rest, which I think is very important, and a lot of things we're learning here, and maybe future for how we treat cardiovascular disease, knowing what ACE2 does. So angiotensin 1 to angiotensin 2 via ACE, and angiotensin 2 either works by linking itself to the AT receptor or gets cleaved into one protein that's called angiotensin 1,7. Now, that is where ACE2 works, by cleaving angiotensin 2 into angiotensin 1,7. Angiotensin 1,7 is a contrarregulatory protein compared to angiotensin. So angiotensin 2 causes vasoconstriction, hypertension, inflammation. We know all this, fibrosis, remodeling. That's why we use in heart failure to prevent remodeling. Causes vascular permeability and causes lung injury. All this effect of angiotensin 2. Angiotensin 1,7 causes the opposite, vasodilation, less inflammation, so it's a contrarregulatory pathway. But the virus uses ACE2 as a receptor. Again, it's not a receptor, but the virus recognizes ACE2, binds to it, and that's how it gets inside the human body by the type 2 alveolar cells. So this is very important, how the virus gets into the body. It took me a couple of hours to come up with this graph, and then yesterday or 2 days ago in New England, they did an amazing drawing. I wish I had it before. Nevertheless, what we learned from SARS-CoV-1 is that the way it binds to ACE is going to cause the virulence. So many different coronavirus out there, but those who link to ACE are actually the ones that are going to be pathogenic to the human. These are examples of all the ones that are pathogenic to the human, and all of them share this spike. Interestingly enough, SARS-CoV-1 and 2 share 80% of the sequence, and SARS-CoV-2 has more affinity for ACE than SARS-CoV-1. Very little data out there about ACE2 and the role in the body, so we have to take this with a grain of salt as well. Studies in humans taught us that yes, ACE2 is present in heart, kidneys, and the lung, in alveolar cells. Animal models have shown mixed data about whether if somebody is exposed to ACE inhibitors or ARB, they're going to upregulate and have more ACE2 levels. We don't know this for a fact, and it's very hard to prove this theory in humans. And circulating levels may not really be correlated with how much ACE expression you have in your lungs, in your heart. And only one study with olmesartan showed that patients on olmesartan had higher ACE2 in the urine. Again, we don't know whether the circulating ACE2 has a direct correlation with how much ACE2 you're expressing in the tissue. So the first theory came like, well, if ACE2 is upregulated in patients with ACE ARB, can we do something to minimize or decrease the ACE2 expression and hence decrease the propagation or mitigation of the virus? Well, we don't know yet, but does ACE2 has any beneficial effect in the human being? I'll say yes. So elderly patients are known to have less ACE2 levels, and these are the patients that have higher mortality and higher rates of ARDS. So is this because they have less ACE2? We don't know. But ACE2, as I mentioned before, increases the production of angiotensin 1, which has a protective effect against lung injury. SARS-CoV-2 not only uses the ENS ACE2 to go into the cell, but also downregulates the expression of the cell. So patients that get exposed to SARS-CoV-2, they have lower ACE2 expression. And if you have less ACE2, you have unopposed ACE activity. With this, you're going to have more angiotensin 2, less angiotensin 1,7. And remember what I said early on, patients with COVID are hypertensive, and they have ARDS, and this may just be due to unopposed ACE activity with increased angiotensin 2 and no angiotensin 1,7 production. So AT1 receptor, so angiotensin going to the angiotensin receptor will increase pulmonary vascular permeability and causes direct lung injury. Animal models back with the SARS-CoV-1 show that if you block the RAS system, then you have limited injury. Again, these are animal models. And if you have somebody on ACE and ARB, whether or not they have higher levels of ACE, but then you block angiotensin 1 receptor, you may shift your curve towards more angiotensin 1, and that may be a solution to mitigate this problem. But again, very little data out there to make any recommendation. This paper published in March with 12 patients that were infected with COVID, they look at viral load, and they realized that the higher your viral load, higher chances of ARDS. And then when they look at ACE level, the higher your ACE2 level, the higher your viral load, and the higher your ARDS. All of these were directly proportional. And patients that had COVID-19 disease had higher ACE2, angiotensin 2 levels. So less ACE2 activity, higher angiotensin 2 levels. And higher angiotensin 2 levels correlate with lower PO2 FiO2 ratio. This is very interesting data. So the pendulum is shifting back and forth. People saying we should use this as a therapy. Some others, let's stop this therapy because it can be the entry of the virus. 2 ongoing trials in University of Minnesota, losartan in patients with COVID-19 in the hospital and outside the hospital. This paper came out yesterday. This has not been peer-reviewed yet. So again, grain of salt with this data. A lot of data is being published without appropriate evaluation. They look at 500 patients. Out of them, 78 had COVID-19 disease and were hypertensive. Among these 78 patients, 40 were classified as mild and 38 had a more severe disease. There was no statistical difference between the severity of the disease and whether they were beta blockers, ACE inhibitors, ARBs, thiazide, in all comers. However, when they look at the patients that were older than 65, remember, older patients may have lower ACE2 expressions. This patient actually, there was a protective effect towards progressing to a severe disease. Again, little data, not enough to make a recommendation at this point. And many societies and committees have come up saying, please do not stop this therapy in patients that need this therapy. Stopping this therapy in patients with heart failure may lead to worsening of heart failure. Hypertension, you're going to have a rebound hypertension. In fact, you need to continue this therapy as of now. We don't really know the exact clinical course of the disease. We're learning as we go. But data from China suggests that 80% of patients will have a milder version. 14% will have a more severe disease, and 5% will have a critical illness. Severity is defined as dyspnea, increased tachypnea, low oxygenation, or a PO2 FiO2 ratio less than 300, and more than 50% lung infiltrates. Now, the critical ones are the ones that need respiratory support, septic shock, multi-organ failure. Mortality is higher in elderly patients. We learned that, we know that, but mortality is the highest among those admitted to an ICU. Critically ill patients have a very high rate of mortality here. Wuhan, China had a 3.8% mortality, but if you look at Wuhan, which was had the problem first, they had higher mortality compared to the rest of the China population. And the same thing was seen in Italy. Lombardia got hit hard, and the mortality rate was 13% compared to the neighborhood city, Veneto, that had 2 weeks apart for the infection to spread, and they had a lower case fatality rate. They had 2 weeks notice. We're seeing a similar thing here in New York. New York is being hit hard right now, and hopefully we can treat the disease and prevent it to spreading like China did, and Wuhan was the most affected city. So why is this important for the cardiology community? Well, we know that patients that have a higher case fatality rate are those with comorbid conditions such as hypertension, diabetes, and cardiovascular disease. You can say, well, you just said that, Gabriel, you just said elderly patients are higher risk of dying. This is an associated error. These patients have higher prevalence of diabetes, cardiovascular disease, hypertension. Well, maybe true, and Italy also showed us that elderly patients had a higher risk of mortality. But let me show you a different scenario. Paper published in Lancet, 191 patients in 2 hospitals. Mortality rate, 28%. 48% of patients had comorbidities. Hypertension was the most common comorbidity, followed by diabetes and coronary disease. And the age wasn't extraordinarily high. 56 was the average age. And yes, the non-survivors were older, but look at the hypertension prevalence, 30% in all comers, but those who died had higher hypertension, higher diabetes, higher coronary disease, and I think this is key to understand what we're seeing now with the cardiovascular implications. Type 2 MI, we forget about type 2 MI. We said, you don't need to bring this patient to cath lab, this is a type 2 MI. Well, type 2 MI might actually be killing people right now, and you can extrapolate this from the fact that this patient has more coronary disease, those who died. Look at the troponin levels. Troponin was higher in those who died. And even though this is a high sensitivity troponin we don't widely use in the United States, a level I think more than 28 for this laboratory was positive. So even though they didn't have truly, when they came, or the average was truly high, when they look at who had troponin more than 28, well, those who died had 46% who died had a troponin higher than the cutoff. And only 1%, one patient that had a high troponin died. So troponin is, or cardiac injury is linked to the problem here. And look how survivors, non-survivors did with, in terms of troponin. Survivors had a pretty flat troponin curve compared to the non-survivors that had a high troponin peak and elevation. And this graph's going parallel with the D-dimer. So are these linked together, high troponins and high D-dimer? Are we seeing a problem with coagulopathy and microthrombi? Maybe, maybe not. So is this not enough information? Is that not convincing enough? Well, let's see another paper by Wang in JAMA. This actually was earlier than the paper I just showed you, the Lancet paper. 138 patients, one hospital in Wuhan. From January 1st to January 28th. Now, when they published this on February 7, sorry, I think more than 30 to 50% of patients were still in the hospital, so they cannot make mortality assumptions here. But interestingly enough, 30% of the patients here were healthcare workers. If you look at age, again, not elderly patients, 56 years old, those who were admitted to the ICU, again, they could not do mortality association, so they did who required RCU or not. Age was higher in those coming to the ICU, and hypertension, cardiovascular disease, and diabetes was higher in those going to the ICU. Troponin was also high in those going to the ICU. And this is very interesting. I think this paper has helped a lot to understand cardiac injury is frequent in patients in the ICU with COVID. They report 1 out of 4 patients in the ICU had acute cardiac injury, and arrhythmia was present in almost half of them. This is the first report from Seattle, published on Monday in New England, and they have 24 patients, age 64, 25% came from this nursing home that we learned in the news. High prevalence of diabetes, we just don't know what was the prevalence of hypertension, coronary, or cardiovascular disease was not reported. Not many patients had a troponin elevation, but note that in the United States we use regular troponin, not high sensitive troponin, which may be the right way of detecting early cardiac injury. Mortality was very high here. This case report is very interesting. They did a great job reporting what happens in the lungs. However, I think this paper has been misused in the cardiology field, and I see this paper has been quoted in all webcasts, podcasts that I've been seeing, saying that coronavirus does not affect the heart, and we'll see why this is not true. 50-year-old man comes to the fever clinic with a fever, caution of breath. Symptoms started on January 1st. By day 9, the CDC, the Beijing CDC confirmed he had COVID-19. By day 12, he was in respiratory failure and he refused the ventilator, so high-flow nasal cannula was given. 2 days later, the patient died of hypoxemia. He had a PEA arrest. This was not a cardiac cause of arrest. This was never reported that the patient had high troponins, low EF, chest pain. We cannot tell that the patient had any sort of cardiac injury. The patient got standard therapy, steroids, well, not even standard because we don't know what standard therapy is, but he got steroids, antibiotics, Calitra, antiviral, and interferon. Pathology showed of lung, liver, and heart showed that the lung had ARDS, highly membrane, everything that we learned that is a pathognomonic of ARDS. In the heart, they didn't find much of an inflammation. And this pathology slide is being shown over and over again saying coronavirus does not affect the heart. You cannot tell this because this patient did not have acute cardiac injury. We know from the SARS-CoV-1 that 35% of autopsies showed viral RNA in the heart. HFSA news, please share your stories, share your cases. We need to learn. John Lindenfeld and Javed Mosleshi are asking for pathology samples to collaborate and try to understand what is going on here. ACC also saw these increased rates of acute heart failure, MI, myocarditis, and encouraged cardiologists to be prepared and to help other specialties. We need to support our critical care staff with BA, BB, ECMO cannulation as needed. And what are the potential mechanisms of injuries? And I've tried to summarize everything that I learned into this slide. Coronavirus will have a direct cardiac injury, which may be due to direct viral effect, where this is associated with upregulation of ACE receptors, ACE2 enzyme in the heart. We just don't know. Is this due to massive inflammation, cytokine storm? Is it due to hypercoagulability, and that's why we're seeing elevated D-dimer levels? Is it due to sympathetic activation, hypoxia, vascular inflammation leading to plaque rupture, and that's why we're seeing more STEMIs, type 1 MIs, myocarditis, Takotsubo, arrhythmias, cardiac arrest? This may be one mechanism, but there's another mechanism that requires the patient to have a comorbid condition like hypertension, like coronary disease, like diabetes, right? And that's why we're seeing what we're seeing. So hypoxemia can worsen problems in somebody that has already heart disease. Sympathetic activation will lead to demand ischemia. Massive PEEPs, massive alveolar recruitment may harm the heart. At least patients that may have underlying RV failure may be harmed by high PEEPs. Fluid shifts, hypertension, all this can lead to acute decompensated heart failure, diastolic dysfunction, worsening pulmonary edema, type 2 MIs, and worsening right ventricular failure. And these are not exclusive. Multiple mechanisms can be triggered at the same time and causing the amount of acute myocardial injury. Last mechanism that I think is important is side effects. A lot of these medications are causing QT prolongations, electrolyte alteration, interactions among other drugs, and some of them linked to cardiomyopathy. And again, these are not mutually exclusive. So what are the therapist options right now? Hydrochloroquine, known to cause QT prolongation. Plaquenil actually can cause cardiomyopathy. Platinum-induced cardiomyopathy is a known thing. It's usually a chronic condition that we see very rarely, but in patients that have been on plaquenil for a long time. But when you add azithromycin to the picture, you get even more QT prolongation and higher likelihood of developing torsades. And there's multiple reports of torsades or BT in patients, polymorphic BT in patients that are taking these medications. And ACC actually have a guideline on how to triage who can be safely started on this medication and who needs to be monitored sooner. Calitra recently published, not much effect, but it also can cause QT prolongation. So if you add these three drugs, then yes, you may have more cardiovascular problems. Calitra can also cause AV block. Remdesivir from Gilead is a newer medication, so we don't really know cardiovascular effect yet. Tocilizumab, IL-6 inhibitor, may not be linked to heart problems yet, but we know it can cause infusion-related reactions. And some other medications, IVIG, may give you a lot of volume if you need to give high-dose IVIG, convalescent plasma, steroids, for example. CardioNerds, it's a group of fellows that are on Twitter, and they are doing an amazing job teaching us about disease as we go. And they've came up with a similar mechanism of injury and whether ACE2 is related or not. We're seeing more and more hyperinflammation syndrome with COVID, and this may be something to target therapies. And hyperinflammation, it's more like a secondary hemophagocytic lymphohistiocytosis. And there is a calculator online for a hemophagocytic syndrome, which will tell you whether the patient is at a hyperinflammation state or not. And this may be, again, one of the potential ways of treating these patients. We know from SARS and MERS that steroids are not recommended, but they did not develop this hyperinflammation syndrome that we're seeing now. And tocilizumab and counteracts the cytokine storm is being studied right now. This is a very interesting mechanism proposed by Dr. Mera that divides the disease in 3 stages. First stage, stage 1, is the viral response, the viral action on the host. And this is where 80% of the patients will stay, mild symptoms. But then if you progress to stage 2, a more severe disease, you start getting host inflammation. And when you're in stage 3, that's the hyperinflammation state. I actually think one great option will be doing viral replication. And once you know you have no more viral replication and you're in this hyperinflammation state, that's where you have to throw the kitchen sink at steroids and every immunomodulator you can give to prevent this hyperinflammation. This may be one solution in patients that are dying. What Italy taught us? Well, they actually had lower rates of arrhythmia compared to Japan. Hard to explain, we'll learn as we go. But they also reported less ST elevations, MIs. They said maybe a competing risk. Now, this is not published data. These are webcasts from the European side of cardiology. They did notice a delayed presentation. Patients have fear of coming to the hospital. We saw this last week, and last week a patient came very late because he did not want to come to the hospital. And we're seeing this, and also calling ambulance. Ambulances are busy with COVID patients, and they are not getting to patients as quick as we used to. STEMIs are still being treated with primary PCI in Italy, but they mention you have to expect extra delays. So if your case is going to be, your door to balloon is going to be delayed, consider fibrinolytics. This doctor in Lombardy, I think, said 60 minute delay. Our current guidelines are 120 minute delay. That's when you think about fibrinolysis. All STEMI patients were assumed to have COVID. Now, they test everybody there. We may need to be more judicious about who we test because we want this test to be to reach the community and those are really infected. Non-STEMIs, they shift from early invasive to strategy to conservative strategy approach, rely a lot on CTAs, a lot of troponin peaks and EKGs that we were not used to. An initial analysis in Lombardia, out of 33 patients that present with ST elevation in the EKG, high troponins, 81% of them, wall motion abnormalities, 100% of them, and are more than 50% with low ejection fraction, well, they were taken to the cath lab, and 60% of them did not have a culprit. They didn't require a stent. So, well, whether this is myocarditis, we don't know. We didn't have biopsy. This is a spasm from sympathetic stimulation. We just don't know. But not every patient that comes with ST elevation may be having a true STEMI. Paper from Japan, from Hong Kong. 7 patients are presented to the hospital without COVID. Door to balloon was delayed. Symptoms to first medical contact was delayed. Door to device was delayed. Right? So we have to expect, even in non-COVID related patients, that we're going to see a delay in door to balloon. So myself and my interventional colleagues here came out with an algorithm how to treat patients with suspected ST elevation. And we rely a lot of the SCI and ACC recommendations. So this is how I see things. You have ST elevation. This is either a classic MI, classic STEMI, 60-year-old coming with chest pain, grabbing the chest, ST elevation anteriorly, reciprocal changes. Common things are common. STEMI, if you can take him to the cath lab, let's do primary PCI. We are going to take to the cath lab most of the STEMI patients, and we have a designated COVID catheterization laboratory and another lab for STEMIs that are not COVID or presumed COVID. And I think this is key. We can bring this patient to the cath lab. One thing that we need is patients is not going to come to be intubated in the cath lab. Patient needs to be intubated. It's intubated down in the ER. We are not going to transport non-invasive ventilation. The risk of spreading the disease is high. We're going to expose our staff and the cath lab and maybe different cath labs with a non-invasive ventilator. So if the patient needs to be intubated, gets intubated before coming to the cath lab. And cardiac shock patients should come to the cath lab. So who would we consider lytics? Hopefully a very selected group of patients and the minority, those who are truly going to be a door to balloon more than 120 minutes, that we do that routinely as per the guidelines. If the COVID cath lab is occupied by another STEMI, if the patient cannot be intubated, he doesn't want to be intubated, or we are running short of ventilators. Hopefully we don't get there, but maybe we can consider lytics in this patient if there's no bleeding risk. So if that's true, STEMI. If it's a 30-year-old, typical symptoms, patient read the horizon, pain is worse when, take a deep breath, all those things that we learn. Well, if it's truly myocarditis and we know it's classical myocarditis, diffuse ST elevation, then we don't need to bring this patient to cath lab, expose the patient to a risk of procedure and the cath lab personnel to get an infection. So cardiology should be consulted on these patients. We need to do daily troponins. We don't need to do echocardiogram on all pericarditis, on all myocarditis, unless we think it's going to change our management. If we think we're going to need SWAN or MCS, which we should really use it judiciously. I think there's a role for biomarkers, inflammation biomarkers, because these patients with myocarditis, if they have this hyperinflammation syndrome and the myocarditis due to this hyperinflammation, we may need to treat that hyperinflammation. So ferritin, D-dimers, IL-6, whether it's going to change our management or not. Then there's going to be a group of patients that we don't know whether they have myocarditis or not. And unfortunately, there's going to be a vast majority of patients. So we need to use our clinical gestalt. Maybe repeating troponins not every 6 hours, but get one and get the second one, see how the troponin rate is changing. Maybe in this patient we'll need an echo if we're not taken to the cath lab right away to see what we're dealing with. Pro-BNP, I think that just going back to the Takotsubo phenomenon, you get more pro-BNP elevation than troponin elevation. Maybe that will make you think this may not be an MI or STEMI, inflammatory markers, and maybe rely on CTA. If you're going to transfer a patient somewhere, maybe going to a CTA makes sense. If the patient is tachycardic, you may not be able to get it. And again, you're going to get a CT scanner infected, and this CT scanner may be needed for somebody else. So what to do with non-STEMIs? We're going to have to do a paradigm shift. We're not going to take all STEMIs to the cath lab as we used to do. Conservative therapies, dual antiplatelet therapy early on, heparin for 48 hours. We did this in the past 10 years ago when I was an intern 8 years ago. That's how we treated patients, heparin, dual antiplatelet therapies, and then decide at what time you take them to the cath lab, right? Unfortunately, this time we're not going to take them to the cath lab if they are stable. But it may be important to check your troponin peak because that is going to tell you the size of the MI, early statins, optimal medical therapy, and again, we're going to defer invasive, non-invasive tests on these patients. Who is going to have an early invasive approach? Persistent chest pain, instability, heart failure, VT, shock. Yes, they're going to come to the cath lab. A special group of patients, maybe somebody comes COVID positive, but they don't have significant respiratory symptoms that are going to keep them in the hospital, but it's a chest pain keeping in the hospital. Well, if you treat the chest pain and you put a stent and you get the patient out of the hospital that same day or the next day, maybe we're going to open up a bed for somebody that needs it. Maybe we are actually, every morning we're discussing these cases with our cath lab team and decide who to bring to the cath lab or not. And I think this is the way things should be done. Type 2 MIs should not come to the cath lab. Type 2 MIs, we need to minimize tests on these patients. But minimizing tests doesn't mean that's a type 2 MI, forget about it, I'm not going to see it. No, we need to be aggressive with these patients because those are the patients dying. We need to control blood pressure, control the heart rate, give beta blockers if the ejection fractions or they are not in shock, early statins, treat the underlying condition, treat heart failure if you need to, try hypertension if you need to, and control the hypoxemia. Since we're going to get called a lot, I think we can safely do e-consultations and just look at the data, make sure you are understanding what's going on and have a close follow-up with the patient. Biomarkers. I advocate towards use of biomarkers if it's going to change your management or you're going to do something about this. There's an interesting response from Dr. Lanucci, who came here recently, and he says, yes, biomarkers are important in somebody with MI, but we just don't know in those without an MI whether troponin is important or not. I think we know, and I think it's important because I show you the data that those who died had a higher troponin. But I think it's important to do a test if you're going to do something about the result. 3 cases really quick. 37-year-old female, ST elevation, taken to the cath lab, no coronary disease, EF 27%, a little big diastolic diameter, 5.8, troponin through the roof, and pro-BNP through the roof. IVIG, steroids, 2 weeks later, EF recovered. Another case, these first 2 cases from China, 63, they call it acute respiratory respiratory failure, and fulminant myocarditis, EF 32%, a little bigger LV, troponin and BNP through the roof, got ECMO, IVIG, steroids, 2 weeks later, EF recovered. Last case, 53-year-old female, chest pain, diffuse elevation, MRI done, ejection fraction 35%, typical, they say, findings of myocarditis, late gadolinium enhancement, proBNP higher than the troponin, which is what we see in Takotsubo or in maybe myocarditis. Inotropes, antiviral steroids, and patient recovered. So I think it's important to do biomarkers, but if you're going to change therapy, like these patients were in the hyperinflammatory response, myocarditis, and again, you don't have biopsy, but that doesn't mean that you're not going to treat the patient if you think this is a myocarditis. Very important study, very recent, 187 patients with COVID-19 in China, high mortality, similar age. What is important here is that they look at troponin elevation. Those patients who had high troponin were higher likelihood of having hypertension, coronary heart disease, cardiomyopathy, of course, higher rate of ACE inhibitors or ARB use, but this is probably hard to know if this is really causing the elevation of troponin, or these are therapies that these patients were having because of hypertension or higher risk of cardiomyopathy. Whatever it is, we know that high troponin was associated with more ARDS, more VTBF, and more problems. And patients with high troponin died more often. This is very interesting data. Patients with cardiovascular disease and elevated troponin, 70% rate of mortality. Compared to those with cardiac disease without elevation of troponin, it's 13%. So the elevation of troponin is key. And even in those without cardiovascular disease and elevation of troponin, the risk of mortality was higher. So I think troponin is important and is selecting the patients that are high risk and maybe those that we need to see quicker and try to stop the disease process. Similar to the other study, those who died had progressive increase in troponin and BNP compared to those who did not or who survived. Quick word on ECMO. ECMO may be needed in some selected group of patients. And I think the vast majority of ECMO are going to be BV ECMO, and most of them can be cannulated safely at bedside if we use femoral approach. With femoral approach, you have big cannulas, you can flow large amount of blood to oxygenate and to return to the patient. You can also do a femoral IVC approach, however, you do have a risk of recirculation syndrome. So probably femoral may be the most useful in COVID-19 patients. Why is that, and why not the Avalon cannula? Avalon is a great single-access BV ECMO technique. However, one thing important here, you need a TE, you need to guide. So you're going to be pulling blood from the IVC and returning it in the right atria. So you have to have the whole facing the tricuspid valve. So you need TE guidance and fluoroscopic guidance. So you're going to put more cardiologists, more personnel at risk of aerosols while you're doing a TE. And to be honest, the Avalon cannula is smaller than if you have two cannulas separated. So you're going to oxygenate more via femoral than if you use Avalon cannula. Protect Duo, I think selected patients, if they truly have RV failure and need oxygenator, maybe MCS to consider, but again, I think 99% of cases, you're going to use femoral or femoral IVC, SVC approach. You can read this online. Also, guidelines for who goes on ECMO, proning first, neuromuscular block, and then if you're still having problems oxygenating, ECMO, unless they have high CO2. 2 works on BA ECMO, very rarely. And if you use BA ECMO, it's probably going to be BAB ECMO because you have massive problems oxygenating blood. So if you just do your regular BA ECMO where you're draining from the venous system, oxygenating and putting back on the atria, well, the heart is still going to be squeezing. It's going to be squeezing desoxygenated blood. So you need to make a return cannula to the right atria, so the right atria transmits blood to the left atria that is oxygenated blood. Otherwise, you're going to worsen your cardiac ischemia with deoxygenated blood going to the coronaries and maybe giving perfusion to the brain as well. As of this morning, 82 cases of ECMO on COVID-19 patients, 54 in the United States, 22 in Europe. Less than 5 patients were not, if there were less than 5 patients, just to minimize HIPAA and identifying patients, those are not being reported, so maybe it's more than 82 patients. Vast majority of them, 89% VV ECMO, and only a minority with VA ECMO. So what are the take-home points? And I'm done, this is my last slide. When you get called to see these patients, establish your comorbidities first. What is the clinical syndrome you're called about or this patient is suffering? Is it acute coronary syndrome? Is heart failure related? Myocarditis, shock, arrhythmia. So identify your problem and then get your ancillary test. Get your electrocardiogram. You have classic STEMI, intervene. You have myocarditis, well, treat for myocarditis. Supportive and steroids as needed. Equivocal pattern we talk about. Biomarkers, use them if you need them and try to use them judiciously. Imagine, again, very judiciously on echo, minimize echo. Somebody needs to go be there 5-10 minutes, 15 minutes next to the patient getting exposed. So do echo if you need it. We have an echo probe at Dr. McMullen's office that we're going to use. It's portable echo that we're going to use in COVID positive patients. Plan your therapy from the get-go. Early statins. If the patient is on ACE-ARB, do not stop them. If the patient needs to be on them because of acute heart failure and you need to lower vasodilation, then use what we know what to treat. Control blood pressure, control arrhythmias, anticoagulate some patients, and a minority of patients may need MCS, and we're here to help because this is all of us problem. And I found this picture online, which I think is just amazing. Unfortunately, I don't know who drew this to put his name, but this is all healthcare workers' problem. And we may just be this guy here trying to pull the arm, and maybe critical care infectious disease doctors are on top of the virus. But we are here to help, and we want to be called, and we want to be part of this. And I think I have to show my thankfulness to our leaderships who are really up doing meetings every day, up at nights, really fighting this for us. So thank you, everybody. And I guess cannot be open for questions.